Well, again, I want to say good evening to people. Good afternoon on the West Coast. My name's Bill Carrick. I'm the president of the American Society for Addiction Nursing, and I'm also the presenter this evening for our free weekly webinar. There's going to be five more webinars after this one, so I hope that you attend those as well. I'll post those shortly. Please keep your cameras on and mute your microphones. And if you have questions or comments, use the chat room. And at the end of the presentation, Al Rundio will review the questions and hopefully we can give you some answers. So post the questions in the chat box, please. Now you must complete the daily session surveys, and the link to each session survey is on the web page. The web page on our addictionnursing.org web page. All right. This conference has been approved for 8 nursing CEUs through the California Board of Nursing. Now that's this one this evening will be 1 CEU. And hopefully, if you've attended the others, you'll be receiving CEUs, and there will be further CEUs offered with the next 5 programs that we're going to offer. We are being recorded, and these programs, these webinars are going to be archived. If you are unable to participate in future sessions, you can go to the archive, and you can also let your peers know. Or colleagues know that they can go in and review the live sessions. CEs are available for the recorded sessions as well with a completed survey. Here's our distinguished ASAN Board of Directors. These are posted each time. You're welcome to take a look at them. You also can pull up this PowerPoint presentation, I believe, starting tomorrow, so you can review our distinguished board members again. And a number of them are going to be on with us this evening. So what's really important is for people to see that we are going to have 5 more webinars next week. Connie Mealy will be doing the opioid substance use disorder. And then following that, Adam Barrett will be doing stimulant and other substance use disorders. Following that, we're going to have Dr. James Ferguson doing laboratory tests for substance use disorders. And in week 7, we're going to have common psychiatric disorders. I believe I know who's going to present that, but I'll hold off for now. We'll have the presenters up in the next day or two. On our last week, Al Rundio, who kicked off the program on week 1, will also be we'll be putting some closure to it with holistic addiction treatment services. You can see our video archive at addictionnursing.org/summer. All right. I'm going to be the presenter this evening. My name is Bill Carrick. These are my credentials. I'm proud to be a certified addictions registered nurse. I would encourage all the RNs out there to consider certification, and I'm hoping that the LPNs at one point in time will also have a certification that they can go through. I am the president also of Executive Home Detox, Executive Recovery Coach. That's a program that provides an in-home detox to clients who prefer privacy or convenience. The learner objectives this evening are to identify 2 DSM-5 diagnostic criteria for alcohol use disorder, describe 3 signs or symptoms of alcohol intoxication, and identify at least 1 example of autonomic hyperactivity that may be seen in alcohol withdrawal. All right, now that's our learner objectives. I'm hoping that we just get through the whole program because this could have gone on forever, alcohol use disorder. Thank you to our presenters, that's me, attendees and sponsors. We do have a sponsor this evening. Recovery Management Solutions is sponsoring this webinar and sponsoring future events.
Oh, your friends. I was so now we think.
Could everyone please mute themselves? Please mute yourself.
Okay, I'm just going to switch the slide over now, so bear with me. Okay, picking up where we left off. So, alcohol use disorder, where do we begin? I mean, there's so many places to take this. Alcohol use is diffused through our whole society, through the world. So I thought where we begin is social acceptance and encouragement for alcohol use. We use it to unwind. It's a nightcap, takes the edge off. We use it to celebrate. We use it as a toast. We use it at wakes. So not only celebrations and weddings, but alcohol use is used during wakes and for social lubrication. We also use alcohol for religious activities. Sporting events. Super Bowl is rife with alcohol ads. And of course, a lot of partying. And we often, or the industry targets adolescents. I kind of put that underneath the Super Bowl. And alcohol use is a rite of passage in our society. So why I put this up here is that while alcohol can certainly be problematic, and we're going to talk about the alcohol use disorder, apparently it's useful in our society. And we should be aware of that, acknowledge it, and try to find a way to work with that. So one of the things that I like to do is say, how does alcohol serve the client? How is it useful? And is there an adequate substitute? So when we're looking at a client that comes in or a patient that comes in, and we look at them and it's very obvious to us that they need to stop their alcohol use, before we can convince them to stop their alcohol use, we have to know from them, how does alcohol serve that client? Some aspects of alcohol use in the USA. This won't surprise anybody, these statistics, but 85.6% of people ages 18 and older reported that they drank alcohol at some point in their lifetime. I would think it's at least that. Binge drinking in the United States. 25.8% of people ages 18 and older reported that they engaged in binge drinking in the last month. And I suspect there's quite a few under the age of 18. When I first posted what I was going to talk about, I mentioned a historical perspective. So I had to scramble and post this historical perspective. But alcohol and alcohol use disorder was noted by the Greek philosophers. They saw that alcoholism was a problem and a scourge for many of the citizens in Greece. Jumping way ahead to colonial America, there was a societal and medical emergence of alcoholism as a disease. They actually looked at it as a disease model back in those days. There were social reformers and medical observations. It hadn't quite gotten to the medical establishment yet with physicians and people that work with physicians. And as the social reformers and medical observations were noticing that alcoholism was a problem, they were also starting to notice and be aware of illicit drug use, specifically opium. In the early 1800s, there started to be construction of asylums for chronic alcohol treatment. And what they started noticing was a correlation between chronic alcohol treatment and the effects on the stomach and blood. And so we started moving towards a little bit of a science-based observation here. In the late 1800s, the asylums that were built in the rural areas started moving towards the urban treatment centers. And in fact, Bellevue in New York City was one of the first urban treatment programs that was started. And in other urban treatment centers, they had this treatment as well. But then 1900s, there was a demedicalization that occurred. And there was a shift from treatment to prohibition. There was a shift from the disease state of alcohol use to more of control and punishment, except for the wealthy. The wealthy could afford treatment, so they continued to go to different asylums and get treatment. But there was this shift, and it was partially related to the idea that prohibition was a better way to manage alcohol use compared to looking at it as a disease. And also there was economic decline in the early 1900s. And so people didn't want to spend money on treating the alcoholic. It shifted from a disease model to a person of weak character. So instead of it being a disease, you are now a weak character. It shifted from medical to law enforcement. The next big jump happened in 1935 to 1970. Alcoholics Anonymous was started. Also, there was the National Committee for Education on Alcoholism, and they started speaking again about a disease and the science behind alcoholism. Detox wards were created. Hazelden was found. There was support by the American Medical Association, American Hospital Association, NIAAA and NIDA were started, and insurance coverage actually started for people suffering from alcohol use. There were also medication advancements during this time. Then we jump to the 1970s and forward. The American Society on Addiction Medicine started. We have nursing organizations now starting. National Nurses Society of Alcoholism, DANA, CANSA, and INSA all grew out of the movement in the 1970s. And now the American Society of Addiction Nursing is also one of those nursing organizations. There was a return of alcoholism as a disease with an emphasis on the brain and award system, a recognition of dual diagnosis, a recognition of trauma, and there were shifts in the language and nomenclature that we use. And that we can speak to that right now because we're talking about alcohol use disorder and not alcoholism or alcoholics. So again, there's a shift in the nomenclature. 2021 forward, I would suggest we still have a lot of work to do. I think one of the citations I was reading mentioned we are in an area of enlightenment now. I think we can probably become more enlightened as time goes forward as well in our treatment of alcohol use and also drug use. When does alcohol use become an alcohol use disorder? You know, is this a societal determination? We can look at the AA model and determine, use their criteria. Is somebody an alcoholic or do they have an alcohol problem? Or is it a clinical determination? And when we look at this, the AA determination, and AA has been an extremely powerful organization when it comes to alcohol use and the views of alcohol use in the United States. And around, with AA, they say, when does alcohol use become an AUD? Well, they say only you can decide. And while there's no formal AA definition of alcoholism, it could be described as a physical compulsion coupled with a mental obsession. We mean that we had a distinct physical desire to consume alcohol beyond our capacity to control it and in defiance of all the rules of common sense. That to this day is a very good definition of what alcohol use goes through. Now, I will cite AA but I also see AA as a tool and not necessarily a specific treatment. I think AA has a terrific place in our industry, but I also think at times it's amateur hour. And I prefer to use both AA and professionals. And with a clinical determination, we as clinicians have an obligation to inform and decide who has an alcohol use disorder or not. So as opposed to the AA determination of only you can decide, well, people that work with clients suffering with alcohol use, they have an obligation to identify if somebody actually does have an AUD. So we're going to look at the DSM-5 and look at clinical observations, clinician observations in relation to the DSM-5. We're going to look at alcohol use disorder, alcohol intoxication, and alcohol withdrawal and dependence. Alcohol use disorder is very generalized. It can be observed over a 12-month period. It has a continuum of mild to severe alcohol use disorder. When we look at alcohol intoxication, we're really looking at an immediate concern, and it can be an immediate acute concern, or it can be somebody that's engaged in chronic alcohol use, but at this point in time, they need treatment for alcohol intoxication. And when we look at alcohol withdrawal and dependence, we'll look at a medical process over multiple days. All right. So, within the DSM-5 diagnostic criteria, 2 of the following over a 12-month period is necessary. Alcohol is often taken in larger amounts or over a longer period of time than intended. There's a persistent desire of unsuccessful attempts to cut down or control alcohol use. Increased time is spent to obtain or use alcohol. There's a craving or strong urge to use alcohol. Alcohol use results in failure to fulfill obligations at home, work, or school, and continued alcohol use despite recurrent social interpersonal problems are exacerbated by alcohol. Now, there's another list that we're going to look at, 7 through 11, but let's go back to this for a second. So what you're looking for is 2 of the following over a 12-month period. I got to tell you, I think it's pretty easy to identify a lot of people as having an alcohol use disorder according to the DSM-5. I think a lot of potential family members or friends or acquaintances of all of us looking at this, we could look at that and say, wow, according to this criteria, I know a fair amount of people with alcohol use disorder. So we have to be careful with the diagnosis, but we also have to recognize that this is a starting point. Let's see here. In addition to those, 2 of the following over a 12-month period, important social, occupational, or recreational activities are given up or reduced because of alcohol use. Recurrent alcohol use is engaged in physically hazardous situations. Alcohol use continues despite knowing physical, psychological issues exacerbated by alcohol. And there's a tolerance that gets built up. There's a need to increase use, and you no longer get the same effect. Lastly, dependence occurs. So again, 2 out of these 12, and you meet diagnostic criteria for an alcohol use disorder. All right. Looking at alcohol intoxication, and I'm noticing the time, and I think I'm blowing through these pretty quickly. So if people have questions and they're writing them down in the chat room, I'll be happy to take some questions shortly as we can address them immediately. Then I'll continue with the presentation. So I hope that's okay with you, Al. So diagnostic criteria for alcohol intoxication. Recent ingestion of alcohol, of course that's necessary, and there's a clinically significant or problematic behavior or psychological changes that develop during or shortly after ingestion. For example, There may be inappropriate sexual or aggressive behavior, mood lability, impaired judgment, and one or more of the following. Let's see here. Slurred speech, incoordination, unsteady gait, nystagmus, which are eyes make repetitive or uncontrolled movements, impairment in attention or memory, and stupor or coma. So again, I think that alcohol intoxication, there's quite a few people that meet this criteria, and what we do with it is important. With alcohol intoxication, again, there's a continuum, and there's going to be times with alcohol intoxication that you're going to need immediate care. And where that comes down to is treatment with an EMT or hospitalization. And you'll see shortly that this can also lead to treatment in the intensive care unit as we get into something referred to as delirium tremens. So let's see here. Okay, so going through the data, there was a reference of an emerging trend of high-intensity drinking. And high-intensity drinking is considered 2 or more times the gender-specific drinking threshold. Now, in a male, that means that if a male has 10 drinks at a time, or a female has 8 drinks at a time, that's considered high-intensity drinking. And again, this is referred to as an emerging trend. I have a question out there, and is this an emerging trend or just being recognized? Now, I guess I'll spill the beans on my own substance use history. I'm in recovery for 34 years, and much of my drinking occurred in high school or in college, and I felt that this was not an emerging trend back then. This was the regular trend for males to have up to 10 drinks, females to have 8 drinks. I'm just wondering if we're just getting to the point where we recognize this and we have an awareness of this. Also, looking at some definitions here, we have a definition of a heavy drinker by the NIAAA, National Institute for Alcoholism. NIAAA defines heavy drinking as the following. For men, it's consuming greater than 4 drinks on any day or greater than 14 drinks a week. And for women, it's consuming greater than 3 drinks on any day or greater than 7 drinks in a week. Now, I guess that definition certainly has value, but then we jump to SAMHSA, and SAMHSA is a Substance Abuse and Mental Health Administration, and it defines heavy alcohol use as binge drinking on 5 or more days in the past month. So I guess that can be a concurrent definition, but my preference would be that SAMHSA and NIAAA, then we look at the AAAP and other organizations. I wish they would have the same definitions and pare it down a little bit more. Just an editorial comment. Then we jump to the third area for alcohol use disorder. We'll jump to alcohol withdrawal and looking at the DSM-5 diagnostic criteria. So in order to be an alcohol withdrawal, it says that you have to have cessation of prolonged and heavy drinking. One of the things I want you to notice there is it says cessation of prolonged and heavy drinking. And so if somebody is drinking a quart of vodka a day and they drop down to a half a quart a day, they can go into an alcohol withdrawal. You don't have to totally cease the use of alcohol. So That's important to note as well. In fact, there are some people that can go into alcohol withdrawal just by maintaining their current amount because it's no longer an adequate amount. And they either have to increase their use or they start moving towards withdrawal. And what usually happens is that they just start increasing their amount, and before they know it, they're, instead of taking a quart of vodka a day, they might be drinking a quart and a half. Or we are certainly looking at a bottle of wine a night, or 2 bottles, and all of a sudden it becomes 3 bottles. So with the diagnostic criteria as well, you want 2 or more of the following symptoms: autonomic hyperactivity, and that you're looking at sweating or a pulse greater than 100. And you can also have an increased hand tremor, and you can have nausea or vomiting. And we'll continue some of these. But what's interesting to note here is that if we're looking at the CWA scale, and a CWA scale is a scale used to measure what kind of withdrawal somebody might be in. They don't have the criteria for a pulse greater than 100, but it's a very good tool to use to determine if somebody is moving towards withdrawal or still in withdrawal. And you certainly want to have a target of decreasing that pulse from 100 to below 100 and preferably below 90. We get a lot of calls for alcohol use disorder. And one of the main reasons people call us is they notice their increased hand tremor, and they get frightened, and then they want some help with their drinking. So an increased hand tremor is a real red flag for a lot of people that are trying to stop drinking. Nausea or vomiting, just a quick comment on that as well. The thing that might help somebody who feels that they have nausea or vomiting and they are in withdrawal is to actually drink more, because the alcohol actually makes them feel better while it's taking away from the lining of the stomach and the mucosa in the stomach. When you drink alcohol, it soothes that and almost anesthetizes that area. And so the thing that's causing the nausea or vomiting is what they're using to make themselves feel better. It's a terrible cycle. Additionally, you can have transient visual, tactile, or auditory hallucinations. My own experience is you rarely see this anymore, but of course it can happen. You get psychomotor agitation, and that makes a lot of sense because alcohol is a calming agent, and therefore what happens when you take alcohol away is that instead of feeling calm, you feel agitated. Withdrawal symptoms of any substance is going to be the opposite of what the substance does for you. And of course, anxiety and generalized. And if you get to generalized tonic-clonic seizures, you're in serious withdrawal, and you should be receiving treatment. So, so there are life-threatening withdrawal symptoms that I wanted to go over, and one is a seizure. And seizure, I say, requires medical assessment. Now, some people may have a seizure, and they may elect not to go into an inpatient setting or into the emergency room or others. Nonetheless, what it does need is a medical assessment. And so if you're ever in a situation where somebody does have an alcohol seizure, my advice immediately, of course, is to call 911 and engage with the EMTs, and certainly encourage the client or patient to go into the emergency room. And I also wanted to speak about delirium tremens, not tremors. So that's important because a lot of clients and patients think that their tremors are delirium tremens. And the names are certainly similar, but there's confusion amongst consumers out there. And so it's always nice to clarify for them. But delirium tremens is delirium, confusion, and hallucinations, or hallucinations, coupled with fever and tachycardia. And this requires hospitalization, and often hospitalization in the intensive care unit times 6 days or more. I've seen people in the ICU up to 10 days for delirium tremens. Now, this is often not recognized due to rarity, and 50 years ago, it was probably a 3 to 6% incidence, and now it is usually less than a 1% incidence in clients that are going through withdrawal. And so again, it's rarely seen, and that can be highly problematic. I'm going to share one story right now. I've got a lot of stories, but I'll share one story right now with you. I had a client, and we started treating the client in the home, and it was pretty obvious to me that the client was moving towards delirium. And so I alerted the client and the client's family that I thought that he was going to need medical intervention in a hospital if we weren't able to take care of the delirium. We weren't. It moved more towards consistent hallucinations, fever, and tachycardia, as well as hypertension. So I called the EMTs. The EMTs came out and spoke to the client, and the client was able to express himself. And the client said he didn't want to go to the hospital. And the EMTs, not all EMTs are like this, but these EMTs said, hey, this guy doesn't want to go to the hospital. It's not his choice. We can't force him. And I said, he's in delirium tremens, and this is a life-threatening situation. And they looked at me, they looked at each other, kind of rolled their eyes, and said, he's not agreeing to go to the hospital. I said, okay, then as soon as you leave here, and as soon as your ambulance is out of the driveway, I'm calling 911 again. And if they don't take the client to the hospital, then when they leave, I'm going to call 911 again until this happens. So they looked at the client and said, this guy's being a real pain in my back end. Won't you please come to the, won't you please allow us to take you to the emergency room? And so the client said yes, the patient said yes. And so they put him in the ambulance. His wife joined him in the ambulance. I followed. I was delayed in getting there. And by the time I got to the emergency room, his wife came running out and said, he's been seen by the doctor and she's discharging him. I said, what do you mean she's discharging him? The doctor said that all he is drunk, and he doesn't want to stay in the hospital, so he doesn't have to. So I asked the patient's wife to take me back to the emergency room, which she did. And the doctor saw me, and apparently she saw that I wasn't too happy, and she said, listen, this is his choice. He's inebriated, but he doesn't want to stay. And I said, doctor, with all due respect, you went in, spent 30 seconds with this guy, and you made a determination. I said, he's in delirium tremens. He needs to be in the intensive care unit right now, and you need to go back in there. I said, you go back in and you spend 60 seconds with him, and I assure you that you're going to admit him. So she went back in, and about 60 seconds later, she came out. She was white as a ghost and said, we're admitting him to ICU immediately. And so the reason for this story is that it's important with the clients that we are working with from a life-threatening point of view that you are somewhat aware of what DTs are, delirium tremens, and from a more academic point of view, because you're not going to see it that often. Once you see it, you really don't forget it. But there's a lot of people, including physicians, including emergency room physicians, that have never seen this, and therefore we need to be their advocates. So, again, that's my story, and I'm sticking to it. So, alcohol use disorder. What are some of the medical ramifications for alcohol use disorder? Now, liver involvement is well known, and I think part of that comes from the fact that a chronic alcoholic, we can see a liver involvement. You can see that they are puffed up on the right side lower rib cage. But we also can see jaundice and yellow eyes. And we know that that the liver can be highly impaired by alcohol use. 50% of cirrhosis is caused by alcohol use. So again, it's well known. But what isn't well known to a lot of my clients and possibly your patients as well is that there's a terrific cardiac effect. Alcohol has a terrific effect on the cardiac status, all the way from the heart to your capillaries at the end of your fingers and your toes. And it is one of the reasons that neuropathy occurs. And in chronic alcoholics, there's a fair amount of neuropathy that does occur. And the good news is that and many of these other things that I'm going to cite are reversible once somebody stops drinking. So the other aspect I want to mention about cardiac activity is that there's hypertension. And when we go back to withdrawal, there is usually an associated hypertension over a 5-day period. I call it a transient hypertension when somebody is going through alcohol withdrawal, and that can often cease after 6-7 days. Blood pressure may go back to normal. Clients may be on a number of medications, including antihypertensives, and when they stop drinking, it's not surprising that 30 days after they stop drinking, if they remain abstinent, that their hypertension dissipates and they possibly may not need any more medications. The largest organ in our body is the skin, and the skin is highly impacted by alcohol use as well. One of the reasons that some people may want to give up drinking, or one of the incentives, is to let people know that if they don't like the way they look, if they stop drinking after 15 to 20 days, their skin will start improving and there will be a sheen to their skin. And that can be a slight incentive for people to stop drinking. And of course, it has a significant involvement with the brain, and that can include Korsakoff syndrome and Wernicke syndrome. So back 30, 40 years ago, those were referred to in a very distasteful way, but I think a very descriptive way of squash rot or wet brain. And unfortunately, those things still occur, and chronic alcohol use can essentially move the client towards a alcohol dementia. What is lesser known by a lot of people is that there are multiple cancers that are associated with the intake of alcohol, and that includes esophageal cancer, stomach cancer. There's a higher incidence of breast cancer in women that are drinking. So there are multiple cancers that are associated with alcohol use. Now, other medical ramifications come down the line from a behavioral point of view, and we all know about DUIs. And associated with DUIs, there's motor vehicle accidents and deaths related to motor vehicle accidents. Drownings occur because people are inebriated. Domestic violence certainly increases with the use of alcohol. And there's job loss, although that's not a medical ramification. There's job loss. There's also depression and self-destructive tendencies for related to medical ramifications of alcohol use. I'm sorry, but I had mentioned that I might take some questions because I was worried that I was getting too far along. So Al, are there any questions currently in the chat box?
No questions at this time.
All right, good. So we're moving along here. All right. So alcohol use disorder, we're going to look at treatment options, and this is the first slide. So when you're dealing with acute intoxication, again, what you want to deal with is an EMT, and they may determine if somebody needs further treatment. You know, in colleges, there's acute intoxication. There's a number of college freshmen, sophomores, other students that are engaging with alcohol for the first time, and EMTs are invaluable in rescuing these kids and giving them treatment and possibly furthering their treatment in the hospital. So EMTs are a great first line. There's also hospitalization may be necessary for acute intoxication, and then you're going to be treating with fluids. You might have to do lavage, and unfortunately, you may need to do intubation with alcohol, acute intoxication. Alcohol use disorder, there's quite a continuum of treatment. If somebody has, remember that's 2 out of 12 of those criteria. And so this person may have a mild to moderate to severe alcohol use disorder. And what you're looking at then is possibly looking at abstinence or controlled use of alcohol. And the screening and brief intervention tool might be helpful at that point in time. You're also looking at the potential for counseling, group therapy, medications, and self-help groups. Just within the whole continuum. Now, when we're talking about counseling, you might want to consider a KDAC. You might want to consider a advanced nurse practitioner. You might want to consider an MSW, and a number of those counselors can also engage in dual diagnosis therapy. Group therapy is extremely important in treating the client with an alcohol use disorder. And why I say that is that on a one-to-one situation, the client may be able to either argue or they may be able to question the counselor's motives. In group therapy, they're dealing with their peers. And there's quite a bit of power in the peers calling on each other, and I want to watch my language here, but they can call each other out on their stuff. And so if they're in denial or if they're BSing their way through a situation that might have occurred over the last week, there's great power in the group either confronting or supporting the client that is either in denial or minimizing their use. Self-help groups, I have that starred. We've talked about Alcoholics Anonymous to some degree, and a lot of people refer people to Alcoholics Anonymous. I want to take the time now to identify that I often refer to AA as amateur hour. And that's because you don't know who is going to be saying what at a meeting. The chairperson may be a fabulous chair and saying everything in a very ethical, appropriate way. But I've been in a lot of AA groups. Now AA has open meetings and closed meetings, so I'm not breaking any anonymity by saying that I have been to many open meetings of Alcoholics Anonymous, and there are times that the person who is running the meeting is less than stellar. And there are times that people that are in the meetings encourage clients to stop their medication or do other things. Now, don't get me wrong. I love AA, and I think that people who are trying to get sober, if they go to AA, they have an easier time. But my point to all of you is this: if you're referring people to Alcoholics Anonymous, be very clear that you're suggesting that they go to AA and they go to multiple meetings and multiple different meetings and just kind of try it out. I also suggest that if you're referring people to AA, you ought to go to some meetings yourself. Again, they are open meetings. You're welcome to go to open meetings, but it would be helpful for you to probably have an idea of what you're referring the client to. So again, that's a strong editorial comment on my part. Treatment options, again, looking at withdrawal management and medical supervision. So when we're treating the client for alcohol use disorder, it can be done in outpatient or inpatient, residential inpatient. By the way, the SAMHSA identifies that upwards to 70% of people that go through alcohol withdrawal go through it themselves at home. And then 30% use a outpatient setting or inpatient setting. And I suspect that's because a lot of people are in mild withdrawal. And they also reference that some people don't even know that they're going through withdrawal. They may just have some increased pulse and maybe some hypermotility of their bowels. But overall, 70% of people detox themselves in their home. And then again, there's outpatient settings, and that can be office-based. It can be supervised in some way, shape, or form, and residential inpatient settings for medical supervision. You can use the CWA, and the CWA is a scale to determine if somebody is in withdrawal. Now, I don't have a copy of the CWA. You can look it up. But I want to highlight something about the CWA. And again, my bias may be coming out. I think one of the reasons the CWA was created was to justify having clients in an inpatient setting and justify it to the insurance company. And I don't think that's a bad thing. That's okay. My concern is that we often wait too long to medicate people because their CWA score isn't high enough. And so I would suggest that you consider the CWA as a tool, but if a client is complaining of heightened anxiety, if the client is about to sign themselves out because they need a drink and you're not medicating them, I would go ahead and medicate them in advance before it gets to that. I would also, the CWA does not take into consideration any vital signs. So the person may have an inadequate CWA scale to start treatment, at least medication treatment, and their pulse may be 100, and their blood pressure may be up to 150 over 100. I think you have to take a look at the whole picture, and not just base medication management based on the CWA tool. Again, looking at withdrawal management with benzodiazepines. Benzodiazepines are the standard. Now, you can also use phenobarbital, but phenobarbital scares a lot of people. It's a very good medication under medical supervision, but it scares people. So benzodiazepines are still the standard. You want to use something called lorazepam or Ativan as a short-acting benzodiazepine, especially for people that may have issues related to their liver. People over the age of 65, you might want to consider the use of Ativan. My preference is to use Valium or diazepam or chlordiazepoxide, also known as Librium, because they are longer-acting benzodiazepines, and I believe that they cover seizures and also cover delirium tremens better than the shorter-acting benzodiazepines. Adjunctive medicines can also include anti-seizure medications that can be Depakote gabapentin medications such as that. You can also include sleep aids that are not dependent producing, and additional psychopharmacology for adjunctive medication use for withdrawal management. What's really important, whether it's outpatient, inpatient, whatever, is that the client feels some support. If a person is going through withdrawal management, they need medical supervision. And if they can get the support of family and friends, then that's integral as well, especially if they're doing outpatient-related alcohol detox. I also like to throw in here with withdrawal management that you have rapid follow-up with the primary care practitioner, the nurse practitioner, the MD, the DO, physician's assistant. It's extremely important, and sometimes I see clients that have an appointment 1 month out after their withdrawal management. To me, you're missing an opportunity. You want to have a follow-up appointment at least within a week in order to follow up on withdrawal management. 1 month out, it's quite possible that the person won't follow through with the appointment, and you'll lose momentum in treating the patient. All right. Keys to successful treatment. A few things that I'd like you to consider or keep in mind. First of all, this is a process. It's very rare for clients to get it the first time around. They're called one-hit wonders. Most clients require multiple treatment options. One client that I worked with years and years and years ago, and I gave up on, she had 38 detoxes. 39th detox, she got it, and she's been sober since. Use a non-judgmental approach. If at all possible, have adult-to-adult interactions. Not so much clinician to patient interactions. It can get condescending or it can get judgmental. So I find that that a lot of clients or patients appreciate an adult-to-adult interaction. I think I'm a big fan of medications. I'm a big fan of all sorts of treatment options here. But to me, the most important thing in early recovery is positive human connections that support recovery. There's nothing, in my opinion, that improves the person's likelihood of abstinence or moving towards health than having positive human connections that support their recovery. I believe, lastly, I'm going to say nurses and allied health providers are often the last purveyors of hope. And this can put you in a really wonderful opportunity to address some of these clients. Some of these clients, their families have given up on them. They are giving up on themselves. And you may be in a position where you are often their last purveyor of hope, and they won't forget that. So that is the end of my presentation, and I'm happy to take questions now.
Hey, Bill, that was excellent. Thank you so much. Let me see if there are any questions.
Thank you.
I don't see any questions in the chat box, but please, if you do have questions, post them in the chat box. Any questions, comments? I'll be monitoring that. Okay, here's a question. Bill, have you ever seen Vivitrol used for alcohol use disorder?
Oh, thank you. Yeah, I should have probably thrown that in there. I've seen Vivitrol used quite a bit for alcohol use disorder, and oral naltrexone as well. So oral naltrexone and Vivitrol are the same medication. And one of the reasons that Vivitrol might be preferred versus oral naltrexone and Vivitrol is something that can be given monthly, is that it has a steady blood level throughout the month rather than oral naltrexone that has spikes, peaks and troughs. And so there's some speculation that that helps. Vivitrol has about a 44% success rate with clients. The problem with Vivitrol is clients don't know if it's working. they may just say, I don't know why, but I'm just not having the craving that I once had. So it's an anti-craving medication. I'm sorry that I didn't throw that into the presentation, anti-craving medications. But I think it's well worth trying. I like to throw the whole kitchen sink at clients. So I often will see Vivitrol used, Camprol or acamprosate, and also antabuse. I think there's a real place for antabuse for people that are incentivized to use it. Yes, I've seen Vivitrol used quite a bit, and I support Vivitrol.
Hey, are there any other questions? Don't hesitate to post them in the chat box. Bill, while you were talking, while we're waiting for some questions, what came to mind when you shared that case, which was really fascinating, the patient you had and the ER doc, it's unfortunate, but in a lot of our ERs, there's still a stigma against people with substance use disorders. And I also think that's part of our role, which is exactly what you do, to educate and advocate on behalf of the client. So you did such a great thing for that client by sticking to your guns, and I just wanted to mention that.
Yeah, thank you. Actually, one of my staff just had a similar situation occur out in Arizona, and I had to walk him through that because he hadn't seen it prior to this. And they were going to discharge that client as well. So it's repeated itself. And yeah, we certainly need to provide the education. Thank you.
Well, we do have some more questions and comments, so I'll go through them here. Treat the psychiatric disorders as soon as possible, just a reminder. Here's a very good question too. Managing sleep is often a huge problem for folks in early recovery. What do you see as appropriate treatment? Well,
thank you. First of all, if the person, if they're post detox, one of the things that I encourage immediately is walking, and I challenge them to 5,000 steps a day, 7,500 steps a day, 10,000 steps a day, because that's going to help them in so many ways, and it helps sleep. So that's something certainly I encourage. We use a number of sleep agents, and that can range from melatonin. And by the way, if melatonin has been unsuccessful, ask if they've used upwards to 10 milligrams, 5 to 10 milligrams. It's a safe dosage, and it's a fairly benign medication for sleep. So melatonin, some clients do very well with Benadryl. From a prescriptive point of view, trazodone is used on a number of clients. You have to be careful with its interactions with other medications, but trazodone is certainly an option. And we have gone off script with the use of Seroquel in the past, Seroquel 25 milligrams. Now that is up to the prescriber, and you have to be careful in its use. But we've used that as well. So those are some options that I've seen for sleep disturbance for the person in early recovery.
Another question is, please talk more about antabuse more.
Well, antabuse, or also known as disulfiram, is a aversive treatment, meaning that if you take antabuse and you drink, you will allegedly get sick. I say allegedly because there's quite a few people that can drink on it and they don't get really terribly sick. But it's a again, aversive treatment, and what happens is that if a client is willing to take antabuse, and a lot of them are not, and I would never force anyone to take antabuse, but if a person is willing to take antabuse, once they take it, usually that morning, they know they can't drink. And they talk about having stress relief from the idea of obsessing about a drink during the day. They no longer obsess about a drink during the day because they know they can't have one, because if they do have one, they're going to get sick. And so for the right client, it works well. Some clients benefit from somebody giving them antabuse over the first 30 days or so. I do not encourage anything more than that. The client needs to take responsibility for their antabuse after that period of time. Of course, there are exceptions, but the quicker the client can take responsibility for taking their own antabuse, the better. We could have a whole hour on antabuse, by the way, but those are just some quick hits and thoughts. You do need to educate the client regarding other things that may have alcohol in them, including Listerine, mouthwashes, other things. You've got to be careful and educate the client as to ingesting alcohol by accident.
Let's see. I see more faith-based groups and smart recovery being utilized. People seem to do well in them. Do you use them?
I am so glad you brought that up. So, when I had self-help groups there, I meant to bring up smart recovery, Ring, Buddhist-based self-help groups, Celebrate Recovery. Whatever is going to help the client get those positive human interactions that support their recovery, I certainly support. I think smart recovery is an excellent alternative, especially for clients that initially are angry at God and see AA as cult-based or God-based. So smart recovery is a very good option. Again, with smart recovery, I would go to multiple meetings, because what really determines if a smart recovery is going to be good or not is the facilitator. And if you have a good facilitator, often you have a very good meeting. So I would highly encourage the use of smart recovery, of Ring recovery, and other options out there, including Celebrate Recovery, which is Christian-based. So. Big fan of all of those. By the way, while I'm talking about self-help groups, I think women in early recovery should be going to women's groups. I think they should be very careful about going to mixed groups with men in them. It's not the same, and so I'm a big advocate of sending women to women's groups when they're initially in recovery.
And then just a couple more comments. I think we'll be done. We're a little bit over 8 o'clock, but just to mention about the importance of like the vitamins in treatment, thiamine, B12, etc.
Right.
And one person commented they weren't prescribing antabuse because of COVID. Secondary, it's just a good thought to think of too much alcohol-based hand sanitizer. So the hand sanitizer could provoke a disulfiram reaction. So someone then mentioned, what about vinegar?
Yeah, it can. With that in mind, what I encourage people to do is take a little hand sanitizer, put it on their skin, and see if there's a reaction. Same thing with cologne. Same thing with other things that have alcohol in them that are topical. You're not going to cause a severe reaction. You're going to test it out, and most of the time, people can tolerate that very easily.
Well, that's it for the questions. And again, thank you for really a wonderful, excellent presentation. And thank the audience for some great questions and interaction.
Thank you all.
And just a reminder to our audience, if you're not a member of ASAN, hopefully you will consider becoming a member. We plan to do many, many other webinars. Don't forget, we're in our 8 webinar series right now. So we just finished week 3. We have 5 more weeks to go. They are the same time every Tuesday through August at 7 o'clock Eastern Daylight Time. We hope to see you on the next webinar. Thank you for attending. And again, if you're not a member of ASAN, we hope you become a member. Have a great week, everyone.
Thank you, everybody.
Bye-bye.